Okay, we're going to take a look at the cranium. Remember, your cranium is your skull and has your head, your face, your mandible, part of the exoskeleton. Has your brain. Remember, it contains the major portion of the brain, which is the cerebral cortex. You also have the brain stem, that's your basic life functions, and then the cerebellum. Remember, it has three layers that cover it, the dura mater, the arachnoid, and the pia mater. Remember, the dura mater is closest to the skull, bony area, and the pia mater is what actually is covering the brain at that particular point. So you can see that there's the parietal, occipital, frontal, and temporal bones that cover the lobes of the same name. And I found this a couple years ago kind of interesting to show you the different sizes of the brains of the different animals that we deal with. You can see there's some, like the elephant, they're actually a little bit bigger than us, has some of the same areas. The gorilla looks like a mini version of ours. And then you can see the dog, the cat, the mouse too. And so this talks a little bit about what you have with your brain, the cerebral cortex, which is the largest portion of the brain. The brain stem, cerebellum sits behind the cerebrum. You have, remember, the brain stem hooks to the spinal cord through the foramen magnum. You have the cranium, which is the bone, and then you have cerebral spinal fluid that bathes the brain. So there's your four lobes: frontal, occipital, temporal, and parietal. Your frontal is the most anterior. This is part of your body movement, your memory, your temper, intelligence, concentration, personality, your eye movement, your head moving, your sense of orientation, and one of the areas that has language production in it. Now there was Phineas, and I can't remember his last name right now. He was a person back in the 1800s, and he was working on the railroad or something, and one of the spikes came through and went through his head, and that was the beginning of neurosurgery because of everything that happened with him. They were able to study. Occipital is the most posterior. This is basically how we see the world. The temporal is the sides above the ears. This is another area where language is also stored. And then the parietal is near the back top. This one is associated with sensory cortex, process information about your touch, your taste, pressure, pain, heat, cold, and then works on a little bit of all of those. And just shows you kind of a cool picture. So the cerebral cortex says the bulk of the brain. Remember, you have both the right and the left hemispheres. The corpus callosum connects the two portions of them, and it integrates what's going on or what you're seeing. If you're born without a corpus callosum, now you've got two parts of your brain, and you have to be able to train yourself or be trained in recognizing that you have two different things that are actually happening at that particular point. Remember, you have your neurons and your glia, and then they form all the areas of the cerebral cortex. Okay. If you remember, here's the cerebellum, and it's sitting there beneath the occipital lobes. If you remember with your cerebral cortex, what happens is you see something coming in, and the right is actually the left, and the left is actually the right. And so if you have a damage on the left side of the brain, it's the damage that actually occurs on the right side of the body, and vice versa. With the cerebellum, if you damage the right, you damage the right. If you damage the left, you damage the left side, okay? It's important for gamers because you have the ability to perform rapid repetitive action, gives you your sense of equilibrium, gives you your sense of balance, helps you maintain your posture. And then remember, you have the midbrain hypothalamus. You get messages to the pituitary gland. It handles your information for the autonomic nervous system. It is your body's thermostat. It controls heat and cold. Okay. And then there's the brain stem. Remember, the brain stem is attached to the spinal cord through the foramen magnum. It holds up the cerebrum. And then remember, you have the three main structures, the midbrain, the pons. Remember, the pons has got the apneustic center which actually stops you from inhaling, gives you a really good inhalation, but not a prolonged inhalation. Medulla oblongata, this is your breathing, heart rate, basic life functions, okay, are in that area. And one of the major concerns you have with head injuries is if that brain stem is herniated through the foramen magnum, it swells and you're going to lose all those basic life functions. That just shows you again the different portions of the brain. And here's your 12 pairs of your cranial nerves. You don't have to really know them all, but just remember they do specialized things for us. All the good ones. Remember, the vagus is one that we really are interested in. Okay, and then the cranial nerves, except for 1 and 2, originate in the brain stem, and that includes your midbrain and your pons and the medulla, and then the other 2 originate much higher at that particular point. So head trauma, very epidemic in the U.S. Head trauma can be caused by anything as simple as a blow, and you can end up with a traumatic brain injury. It basically will disrupt the normal function of the brain. It can be mild, where you just have a brief change of mental status or consciousness, to severe, where you're going to be unconscious for 30 minutes or more at that particular point in time. It can have prolonged amnesia. You can have a penetrating skull injury. It's interesting to look at x-rays where people have been stabbed in the head and to see the knife actually go around the brain and not into the brain. So it's like, yep, if you have an interest in that, you can take a look at it. You can either have a short or long-term disability, just depending on what type of injury you have. We had a gentleman who had never been to the doctors. He had retired. He was working on his truck. He ended up getting hit in the head with the hood of the truck and unfortunately almost died. He was in the hospital for over a month. So there's about 2 million medically attended cases per year, about 400,000 hospitalizations, about 75,000 will die. It is a major cause of permanent disability. The leading cause of death, as you can see in 15 to 40, a lot of these are sports-related injuries at that point. So how do we know that you have a head injury? We'll see a scalp wound, we can see a fracture, especially around the orbit. You have swelling and bruising somewhere in the face too, or towards the back of your head at that skull at that point, a loss of consciousness, nasal discharge, and a stiff neck. So brain injuries, for the most part, arise from your brain skull anatomy. Remember, your skull is rigid, your brain is soft. And when something soft hits something rigid, you're going to go ahead and end up with some problems. And some of the first things we see are contusions or hematomas on the surface of the brain. You can also end up with concussions too that go with it. Okay, and so there it is. A little bit about those. We're going to talk a little bit more in a minute here. The brain is soft, sits atop the brain stem, and it's all because of what's happening to it. Okay. So one of the things that when we're looking at head injuries, we want to know about where was the person injured. And we have the coup and contra coup injuries. Your coup injury is the first injury. If your brain, and especially if you have a shearing injury or something along that line, the brain hits the skull, and then it bounces back, and that's your contra coup. So not only do you end up with the one injury, but now you've ended up with 2 injuries at that particular point. Sometimes your head injuries can be injuries by themselves. It just depends on what's going on with the head at that particular point. So some of the types of head injuries we see are skull fractures, linear, diastatic, basilar, or depressed. Linear, we see a lot more of those, and we'll see that a lot of times on autopsies. Hemorrhaging, you have subdural, epidural, or intracerebral. You can have a closed, which is your concussion or contusion. We see a lot of people of age, elderly folks that have cerebral contusions. And part of the cerebral contusion is, remember, we talked the other day and said that the brain has a tendency to start to shrink a bit. And now you have more room for that brain to bounce around and cause some problems with it. And then we have brainstem herniation. That's when the brain swells. Thing you need to remember, and I'm probably going to say this again, when you look at your skull, you got 100% of whatever you need in there. 80% brain and about another 10% that's blood and about another 10% that's cerebral spinal fluid. When the brain is injured, there's no room for the brain to expand or swell. And so what happens, it's going to be pushing up against the skull. And when it does, it's going to cut off the blood flow. It's going to cut off the flow to the cerebral spinal fluid at that particular point. Once it's done as much of that it can do, then it has to go ahead and continue to swell. This is where your brainstem herniation takes place. Okay. And these are the different types of bone fractures that we just talked about. You can see the linear is up top here. Here's a diastatic. It looks like a star. A rock hit your windshield. Here's a open. Here's a closed. And down here is the basilar fraction. And the basilar fractions are kind of interesting because we see the results of these about 12 hours after the injury has occurred. One of them that you can see, we're going to see in just a minute, but you can see also depression fracture and then a compound fracture that goes with it. This is called the battle sign, and this is because of the basilar fracture. And like I said, it takes about 12 hours for this to show up. The other injury we see with this are your raccoon eyes. And the same thing, it still takes about 12 hours for these injuries to show up. So with your hematoma, your subdural hematoma is a collection of blood between the brain surface and the dura mater. Okay, it can be the result of contusion or laceration of the brain, tearing of the vessels in the bridging the subdural space, or the extension of an intracerebral hematoma. Okay, you may or may not have a skull fracture. An acute subdural hematoma occurs within about 24 hours. Anything between 2 and 10 days is subacute, and then anything after 2 weeks is chronic. And so what you basically have to look at is what's going on with this patient in these different time frames. Okay. Basically, the time of development and the degree and rate of the neurological dysfunction depends on really a lot of factors. The older you are, the longer it takes. We had a gentleman who was an older gentleman, had fallen. He was brought to the hospital. He had a headache and everything. They went ahead and examined him. He appeared to be okay. Went home. The next weekend, he came back in and actually died of a hematoma. In children under 2, when we see subdural hematomas, it's like a bulging fontanelle, and they also have retinal hemorrhages at that particular point. Your acute hematomas are associated with a high morbidity and mortality, okay? And this has to do with the severity of the injury and the rapid rising of the intracranial pressure, okay, at that particular point. And we see a lot of cerebral edema. The cerebral edema, as I explained, your brain can only swell so far and so much before it has to go ahead and start herniation. Okay. They do CTs on these, and then they can decide whether or not you have to do surgery. If your cause is from a mass effect, you got to have to have surgery. If it's from a cerebral injury, then controlling your ICP or cranial pressure is the most important thing that we can do at this point. So there it is. It's contusion or laceration of the brain. May or may not see that skull fracture. The different time periods. We want to go ahead and control ICP as best we can. You also have acute or subacute epidermal hematomas, and they can occur in about a couple of hours. Okay, 90% of these occur with linear fractures, and the other 10% are blunt trauma with no evidence of a fracture. So what do we see with these for the most part? You have transient loss of consciousness, recovering with lucidity, a secondary onset of a headache, and decrease in level of consciousness. And what they think this is that you have spasm and clotting in the artery and the bleeding stops. And then over the next several hours, the artery will start bleeding again. It forms a hematoma that strips the dura away from the skull at that particular point. Once you see the headache with a decreasing level of consciousness, you already have an increase in the rise of the ICP. You're going to have distortion of the brain with significant mass effects. And you've used up all your compensatory mechanisms, unfortunately, at this particular point. Dilation of your ipsilateral. Remember, ipsilateral, the side of the injury, contralateral, the opposite side. But in this case, you have dilation of the ipsilateral pupil because your third nerve is being compressed by the herniating temporal structures. You're going to become unconscious. Posturing, remember, decorticate, decerebrate at that particular point. And then what's going to happen at this particular point in time? Unconsciousness, your Cheyne-Stokes respiration. Anybody tells you someone's doing Cheyne-Stokes breathing, that is not a good sign, okay? Loss of pupillary response. Normally the pupil will blow at that point. Caloric response, we're going to talk about those, bradycardia, and death. Now you have to do surgery on these folks, but the problem is only 33% will appear with a headache and a decreasing level of consciousness. Another 33 are unconscious from the start, and the final one, 33% are never unconscious, okay? And what we see with children, bradycardia and early papilledema, swelling of the optic disc, it may be the only sign that we have this type of a hematoma occurring. And this shows you in the picture here the epidural hematoma, the subdural hematoma. You can see at this particular point, you also have the intracerebral hematoma. You can see the blood, how the brain is pushed, and you can see the center portion of the brain is being pushed over. There was somebody that remember that they had a head injury and they were actually seeing like double vision, and they were because that center portion of the brain had been pushed over with the swelling of the brain. Intracerebral hematoma, this is brain movement. You can see them on CT scans. Your clinical picture can go anywhere from no neurological defects to very deep coma. Okay. What we see with this, for the most part, patients with slowly accumulating frontal and temporal hematomas frequently demonstrate a rather slow deterioration, okay, with minimal focal signs during a 24 to 48 period. And then if you're not careful, now you're going to have a sudden change in your intracranial pressures, and this recurs from seizures or suctioning and can result in herniation. The other thing that can happen is patient with delayed hemorrhage. These have improved level of consciousness over a 10 to 14 day period. Then they're going to start to get headaches. Now I'm going to tell you, if you have a brain injury, this is not your headache. This is not that, oh my gosh, I have a migraine. This is, oh my gosh, this is 3 migraines in one. Okay. So if you ever have someone tells you this is the worst, absolute worst headache ever had, be careful because they'll probably have a brain injury somewhere. So then these guys will end up with neurological deterioration. We don't know why this occurs. They normally think it's the same old hematoma, okay? And what you need to do is you have to go and take them in and evacuate them. Mortality after surgery is greater than 42%, okay? So there it is, the different frontal and temporal lobes. There's the 2 different time periods. You also have hairline fractures, and there's a subdural hematoma. So there's 2 types of closed head injuries. One's a concussion, one's a contusion. Depends on what's happening. With a concussion, for the most part, you have some transient alterations of consciousness, Most people recover from this. It may take you about 6 weeks to do it. If you die of a concussion, it's because you went into apnea and you didn't start breathing. Okay. Cerebral contusions, though, that's something else. We see this with some of our people of age, the older adults. And 75% of patients who die from head injuries had cerebral contusions. And these occur normally after head injury. Okay. We don't normally see contusions in children, but we do see the concussions. And most of the time we don't do surgery on these because we don't really like removing brain tissue. And however, if you've had some brain shifting going on, or if it's over the frontal or temporal lobes, we can always do some surgery to try to see what's going to happen. The big thing with this, again, is control your intracranial pressures. And this is an interesting one. This is an acute brain contusion, and this is a person who had a high-speed motor vehicle accident, and they had some contusions up front. You can see the arrows as far as that goes. And this is a lateral view of a brain with contusions. Okay. And here's your coup and contra coup. Remember we said the coup was the initial blow, and then you have your forces, and it sends the brain back, and there's the contra coup at that particular point. So different types of brain injuries: traumatic, acquired, open, closed, and different levels, mild, moderate, or severe. It's interesting that some people will end up with brain injuries. We have a friend of ours who has had like 2 or 3 major brain injuries, and his physician has basically told him, another one, you're probably not going to make it through. So some of our traumatic brain injuries, this is your brain or head injury. Head versus windshield is another one. You can also see with this with whiplash and shaken baby syndrome. And we see that with your closed end or your penetrating at that particular point. It's caused by the external force of the brain bouncing around inside the skull. You can have diminished or altered level of consciousness. It impairs your cognitive abilities, your functioning. It also disturbs emotional or behavior functioning. The friend of ours that we were talking about, for the most part, he can be sitting there having a conversation with you and then just suddenly get up and walk away. And you're going, well, where's he going? What is this? That's awfully rude. Well, yes, it's from our perception, it's awfully rude. But if you knew that about his head injuries, you would know that that's part of the head injury that he had. That's what has happened to him. So some of the symptoms we see with this: don't want to see spinal fluid coming from the ears or nose, dilated or unequal pupils. You can see this happen. Sometimes you'll see the ipsilateral pupil, and then maybe a little while later, another day or two, you go over and you look at it, and the contralateral pupil has also blown at that particular point. Loss of eye movement's another one. Respiratory failure, unfortunately. Coma, impaired muscle tone and movement. This is where we start to see posturing at that particular things. Vomiting is something that we see quite a bit, and we see that with kids. Lethargy, and then there's that headache and confusion. So what happens with this? Lots of cognitive defects, motor defects, perceptual defects, speech defects. People have to learn how to do things all over again. One of the folks that I was in the military with, his twin brother was over in Kosovo and got shot in the head, and he actually helped take care of him, and he had to teach his brother how to feed himself and bring back some of his language abilities and things along that line. Lots of social difficulties, and this is where those people that don't understand will say they're rude, don't invite them, don't talk to them, don't do this with them, and it's not really their fault. Regulatory disturbances, and then personality changes. The gentleman who had the rail go through his brain. He was been a really nice guy. Everybody really, really liked him. And then after this, he turned into somebody who was a little bit more rude, and people really didn't get along with him very well. Dramatic epilepsy is kind of an interesting one. As you can see, it occurs in only to 2 to 5% of the brain injuries, but not necessarily right away, okay? This is something that can surface years later. And so if you have a major brain injury, you may go, wow, I was really fortunate nothing happened. But say 10 years down the line, you start having epileptic seizures. You need to relate it back to what happened, okay? Remember, you have your grand mal seizure. These are the most dramatic ones. Somebody is seizing, move things out of the way. Don't hold on to them. Don't stick anything in their mouth, and especially your fingers. Keep them out of their mouth. Otherwise, you're going to end up losing them. And what will happen at the end of them is they're very, very tired. They want to go to sleep. You can have partial seizures or focal seizures, very simple or complex. People can be talking to you, and then all of a sudden they stop, and you just look at them, and they're just staring off in space. And then in a very short period of time, they'll pick up the conversation and start right on again. And if you ask them, are you okay? They have no clue what you're asking them or why you're asking them that. Acquired brain injuries, these are cells affected throughout the entire brain. These, depending on what happens, you can affect the thinking skills, their memory impairment. They have psychosis, depression, restlessness. Sometimes they're very combative and they have a lot of hostility. You have the brain injury occurring after birth. These are not hereditary ones, okay? You also have the injury taking place at the cellular level, and these are very similar to your TBIs at this particular point. And sometimes you have these folks that are in these longer vegetative states. There's a program, I'm not sure if you can find it on Discovery or not, talks about a man who slept for 20 years, and it was a person who was in an automobile accident, and he had the accident at the age of 19. His mother had him at her house. He was in a facility, and then she brought him to her house, and she talked to him and took care of him. And after 20 years, he woke up, and he started to talk a little bit, not very clear, but you could understand some of it. And they wanted to study him. Unfortunately, his language had deteriorated quite a bit. He knew a lot of four-letter words, and that was about it. He also thought that he was still 19. He had a daughter, and he thought the daughter was his wife. So he had some issues. But if you have a chance to see or find that program, it's really interesting. So types of injuries that you can have: anoxic brain injuries, hypoxic brain injuries. Causes of these are kind of interesting: airway obstruction, near drowning, throat swelling, choking, strangulation, electrical shock or lightning strike, trauma to the head or neck, traumatic brain injury with or without fracture, MI, stroke, aneurysm, meningitis. You can also have certain venereal diseases, AIDS, some insect-carrier diseases, brain tumors, hypo or hyperglycemia, seizure disorder, illegal drugs, alcohol abuse, carbon monoxide poisoning, toxic chemicals, and on occasions, chemotherapy can cause this too. Okay, so you can see the rest of them at that point. So how do we care for these patients? What are we trying to do? First of all, you're trying to save the patient's life. Second, you want to try to prevent the injury or stop the injury at this particular point. So when you get to the ED, we're going to resuscitate, stabilize, and diagnose. ABCs, CAB, just depending on what's going on with this patient. Fluid monitoring. There's your drugs and assessment. Hypotension and tachycardia are not good things. Okay. So prognosis and treatment, you got to figure out what's going on. You got to do something with the brain. Unfortunately, sometimes we're not going to know what's going to actually be the outcome for years. Immediate rehabilitation. With strokes, with head injuries, you cannot sit around and say, well, let's let them get a little bit better. If we do that, perhaps they'll respond better to us. No, no, no. You need to get in there and start rehabbing with these folks. You need to start working with them. If you don't, you're going to lose that opportunity. And you can see all the different people who make up the team. And we're part of that team on occasions too. So we need to be aware of that. There's a lot of variety of treatment programs out there. You can ride around Tucson and see some of them. So what we're going to do then, we want to know the extent of the damage or a coma person has a neurological deficit. And so there's a lot of different exams that we can do. These are your neuroflexes or exams. And you can do a pupillary examination to see what's going on with the TBI, especially with our patients of severe injury. If they receive muscle relaxants, then the problem is that you're not going to get the results that you need to get at that point. Okay. Remember, your pupil normally constricts to light. When you remove it, it actually dilates. With our patients who have head injuries, a lot of times we don't get any of those reactions at that point. So some of them that we have is the pupil response. You can also do a deep tendon reflex. I remember one time, and it's probably very true, one of the doctors said, no, I can't do a deep tendon reflex because people can sue me for abusing them. I'm like, okay. Doll's eyes, we see that people still using that. A lot of your neurologists don't. Doll's eyes are if you shake their head, their eyes go everywhere where they're not supposed to. They don't follow. Pain response, that goes along with the deep tendon reflex in some cases. Cold caloric is kind of an interesting one. What they do is they take ice water, literally ice water, and you put it into the ear canal. Your initial thing should be to turn away from it, but if you have brain injuries or you're no longer with us, you don't move at that particular point. Your Glasgow Coma score, remember here and now, there's your posturing, lucidity, apnea test. What they'll do sometimes is that we'll go ahead, and it just depends on who's doing part of the apnea test. We'll go ahead and still give these patients oxygen. However, we don't ventilate them, and what we're waiting to see is whether or not their CO2 is going to go up. And David was talking today that there's something like if your CO2 is 20 millimeters mercury higher than when you started the test, or above 60, that means that you have brain death. Okay, so they'll sometimes do this apnea test as part of the donation too. The donor center will come and do these tests. So what they basically do is, like I said, they give you oxygen and everything, and then you do either series of 2 or 3 ABGs, and what you're looking for is no response in the respiratory center and an increase of your CO2. And again, here's your Glasgow Coma score. Remember, 15 points, eye, verbal, and motor. The basic one is 111. Minimum score is 3. You have different abnormal breathing patterns that we can take a look at. There's Cheyne-Stokes. That's not a good one. Okay. Central neurogenic. This is like 40 to 70 breaths per minute without affecting your CO2 or your O2. Okay. Biots, rapidly short or uniform deep, followed by periods of apnea. Ataxic, very irregular. Sometimes biots and ataxia are put together. Apneustic, this is your prolonged inspiration. Then there's a pause, and then you exhale, and then you go back into another prolonged inspiration at that particular point in time. Very interesting to watch. And then with our intracranial pressures, normal intracranial pressure is normally 0 to 10 millimeters of mercury. Sometimes I'll tell you up to 15. Most of the time it's 0 to 10. If you remember back in therapeutics when we talked about doing chest percussion and things like that, we talked about if your intracranial pressure is greater than 20, we're not going to put you in Trendelenburg, we're not going to do other things with you. And that's the reason why, is because we don't want to increase that pressure at that point, because you're going to stop blood flow and cause problems. So my number's a little off, but there it is, 80% of the brain, 12% of blood, 8% of cerebral spinal fluid. You got to stop something when the brain is swelling, okay? And so, unfortunately, the results are going to be pretty bad. So some of the signs and symptoms, for the most part, headache, 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 nausea, vomiting, altered level of consciousness. Then we're going to see then later on an increased systolic pressure, a widened pulse pressure, and decreased pulse and respiratory rate. There's different Cushing triads. It just depends on what you're reading for the most part. With the Cushing triad, you have some very specific and non-specific symptoms and signs. You can have headache, papilledema. Remember, that's the swelling of the optic disc, vomiting, are some of the classical presentations of increased ICP. Other things we may see, tumors, hematoma, blood pressure going up, going down, bradycardia, and then some apnea on occasions too. Brain shift, double vision, dilated pupils, loss of eye movements, different things like that will happen with it. What we see with children for the most part, when children wake up in the morning, they sometimes have drainage of the cerebral spinal fluid, and that will cause them to start vomiting. Okay. So how do we measure ICPs? Very variable over 24 to 48 hours. You have your closed fluid systems, which are fairly accurate, but we have better ones. We actually have epidural catheters we can put into the ventricles and be able to measure the pressure at that particular point. Okay. Other things that we can do, there's your electrodes with this. Other things we can do are pulmonary artery catheters. We can also do arterial lines, and we can watch what's going on with those too, because that'll tell us what's happening. There's your ventricular catheters that go along with the epidurals. We can put bolts in. You have bolts that they'll put into the head, and we're able to measure the pressure at that particular point. Now, a lot of these patients you're not going to lay down. You're going to see that here on the next slide. We keep these patients about 45 degrees, and that's to help remove some of that fluid, because we don't want that fluid building up. So the head in the semi-Fowler's position. Diuretics, we're going to use both osmotic and your Lasix, your loop diuretics. The osmotic diuretic we normally use is mannitol. Okay. And I said for the semi-Fowler's position, 30 degrees is the most we want to do. I'm sorry. But we want to keep the fluid from building up. Okay. Diuretics, for the most part, like I said, we have mannitol that'll cross the capillary wall. It's not metabolized in the blood, remains entirely in the extracellular effect. Problem with this one, it lasts for about 4 to 6 hours. However, it can cause acidosis and renal failure. So you have to be careful with those. Steroids, remember steroids are anti-inflammatories. We can give those to you to try to control the inflammation. Hyperventilation, remember when you have a patient who's breathing their CO2 down with their hyperventilation, we're going to get vasoconstriction. And so you have to watch that you don't go too low, because now you're not going to feed the brain at all. You can maintain that vasoconstriction probably for about 2 to 3 days. And what you have to do within that 2 to 3 days is start letting that CO2 rise a little bit. And because the body recognizes CO2 is between 35 and 45, that's normal. It doesn't have a problem with it. If you keep it constricted for beyond 3 days, the body sits there and goes, that's the end of it. We're going to go ahead and open up those vessels, and now you have vasodilation. And remember, with vasodilation, more fluid is entering the brain at that particular point in time. Hyperoxygenation may or may not work. We're still working on that one. The hyperbaric chamber, sometimes they'll try that, but it's not really proven out as well as we'd like it to. You can use barbiturates to induce a coma, keep them in there, because now you control everything. Autoregulation is very interesting, because autoregulation is basically the brain is able to maintain its blood pressure independent of the blood pressure in the body for a short period of time. What you have to do is get the body's blood pressure almost back to normal, right around 120/80, to keep the brain doing what it needs to. If you let the blood pressure in the body sit at 80 over whatever, eventually that autoregulation is going to be lost. And when it does, then the pressure in the brain is going to go down. And you have cerebral perfusion pressure. And we know that if your cerebral perfusion pressure is right around 60 or so, we have a good chance of keeping you. Once you get below 60 and you start going down, there's a good possibility we're never going to get you back at that particular point. So it's something that we really have to watch and see what's going on with it with our patients. Okay. And then this is just showing you some head injuries at this particular point. And you can see the different swellings and contusions and things like that. Now, one thing, if you've not worked around neurologists, one of the things you're going to see is they're a little bit different than other physicians. They work with patients who are not like patients that we normally see. Some of our neural patients look wonderful. We think they're going home, that everything's going to work out really well for them, and then the next thing we know, they're dead. We've also had some patients that looked really, really bad. We thought that they were never, ever going to come back, and they actually go home. So it's just one of those things that if you're ever working in the neural section, you just can't sit there and make calls as to what's going to happen to these patients, because these patients will turn around and do just the opposite.